Hi everybody, welcome to our ISPAH PAHO webinar, Going Global for Local Impact, a preview of the ISPAH Congress 2026. So we're very excited to be co-hosting this webinar with PAHO, and what we're aiming to do is to provide you with some insights into what to expect for ISPAH Congress 26, which will be in Merida in Mexico. We're going to give you some highlights of some of our speakers, including keynote speakers and symposium speakers, and we'll follow that up with a discussion and a panel discussion with our speakers and also our local hosts, who I'll introduce as we go. So my name is Associate Professor Sjaan Gomersall. I am the President of the International Society for Physical Activity and Health, and I will be our chair for today. I am an academic at the University of Queensland in Australia. So first we'll have a keynote preview from Professor Ulf Ekelund. We'll then move into a presentation by Dr. Vanessa Garcia-Larsen from PAHO. We'll have the moderated panel discussion, and then we'll follow with some Congress updates and closing remarks. So why ISPAH Congress 2026? ISPAH is the leading physical activity and public health congress, and we gather our physical activity community every 2 years. We do have a great mix of researchers, policymakers, public health professionals, practitioners and advocates who come together to share their research in this field. And this year, the theme is Going Global for Local Impact. And so we're really placing a great emphasis on being able to showcase research from all around the world, as well as showcasing the local work from Mexico. So without too much further ado, I would like to introduce our first speaker, Professor Ulf Ekelund. Ulf is a Professor of Physical Activity at the Norwegian School of Sports Science. I'm going to share my screen and invite Ulf to share so he can start his presentation.
Thanks. I hope you can see my screen. Thank you, Sjaan, for the introduction. And thanks for challenging to start thinking about my keynote presentation in October. So I think I have a tentative title about, and it's going to deals about what we have learned from 25 years of physical activity measurements with devices. As you may note, I put up my Swedish flag, and despite the Norwegian success in the current World Cup, I haven't changed my citizenship yet, so I'm still a Swedish citizen, despite working in Norway. Yeah, so this is going to be a very sneak preview of my talk in Merida in a couple of months' time. And I do have a few disclaimers. It's going to be a data-driven talk. If you enjoy figures, if you enjoy tables, if you enjoy loads of data, that's going to be suitable for you. Not that much words on my slides, especially not during the talk in Merida. I also had to admit that I'm biased. I'm biased in terms of selecting the studies I will present, and the build-up of the story I will tell is obviously a biased story from my perspective. It's a subjective selection of data presented and the interpretation of data. And I will try to be a little bit personal, because I think the journey of the last 25 or 30 years of device measured physical activity is very much where I have been part of throughout my career. So I asked Copilot to help me with this and draft this graph, and we could think about this in 3 different distinct phases. About 25, 30 years ago, we started with devices, and we started to try to measure physical activity with devices. And we did quite a lot of validation studies, testing out how well these devices worked and how well they were actually measuring physical activity. We could then think about the second phase of this when we start using the devices, trying to understand how physically active are people, are there differences between men and women, for example. And more recently, we have moved into the third phase where we are trying to understand how device-measured physical activity is associated with many different health outcomes. And just during the last 6-7 years, there has been a tremendous increase in studies using devices to understand associations between device-measured physical activity, intensities of physical activity, and non-communicable diseases. Just to start where I came from, this is one of the papers which really sparked my interest in measuring physical activity. It was published in BMJ in 1990, 35 years ago, and it used heart rate monitoring to measure physical activity in children and adolescents in the UK. And they concluded from this paper, but by using heart rate monitoring, that British children have surprisingly low levels of physical activity. There are some criticisms about this paper because they used absolute heart rates, and as you know, identifying an intensity with an absolute heart rate might not be the best. But it was really something that really sparked my interest and kicked off the device measures of physical activity in population studies. However, we also needed to understand how well these monitors, accelerometers, and other devices measure physical activity. And this is just two examples of some of the early works I was involved in, where we tried to understand the relationship between accelerometry measured physical activity and activity energy expenditure measured by doubly labeled water during 2 weeks of pre-living measurements. And you can see that the correlation between activity, measured physical activity, and activity energy expenditure from the gold standard method, doubly labeled water, is pretty good. We also were interested very early on, actually in 2002, to look at the effect of different epoch settings. And today we are trying to measure the raw acceleration signal, but you could compare the time spent in vigorous intensity, comparing 5-second epochs, almost 40 minutes, this is measured in children, compared to 60-second epoch setting, where the amount of physical activity in the same kids are only 10 minutes. So there was almost a 4-fold difference between different epoch settings. In the same study, we also looked at different placements. We put one monitor on the lower back and one on the hip, and there was hardly no difference between the two different placements, suggesting that these two placements are interchangeable. So the second phase is more about the descriptive epidemiology. And in descriptive epidemiology, we are basically asking 3 different questions: where, when, and how. We are trying to understand how physical activity varies over time, how it varies by place, and how it varies by person. And quite a lot of work has been done in this area with devices. And what we have seen in this area when we have measured physical activity with devices, for example, enormous differences between girls and boys, boys and girls. This is data from the International Children Accelerometer database, more than 27,000 children and adolescents from 10 countries. And you can see that this is the age on the x-axis and the difference in total physical activity on the y-axis, with a peak at about 5-6 years and a sharp decline in total physical activity up to age 17-18. A very similar pattern for moderate and vigorous intensity activity, with a clear sex difference already early on. From a very early age, we can see this age difference, which wouldn't have been possible to understand and to distinguish if we used self-reported physical activity. There isn't much of a difference between the sexes for light intensity physical activity, whereas there is an increase by age for sedentary time, and there is some kind of a sex difference between, especially between the elderly or the adolescent males and females. This was a study published last year, which I think was really interesting. It wasn't measured by devices, but they measured physical activity by smartphones, and you know that smartphones can measure steps, and they had a large amount of smartphone users in this study and looked at what happened if you moved in and out from New York City, and if you moved or relocated to an environment that was walking friendly or unfriendly for walking. And moving from a less walkable to a more walkable city, moving into New York or out from New York, was increased the number of steps per day by about 1,100 steps. So this study, cross-sectional data using a smartphone, could clearly tell us something about how the built environment increases walking and impacts on our physical activity. I think this is tremendously important when we are thinking about policy and how to increase physical activity on a population level. The third phase is the association between physical activity and sedentary time with different health outcomes. And this is what we could call analytical epidemiology. We want to try to understand if physical activity is associated with a specific health outcome. What is the magnitude of that association? Are there intensity-specific associations? Is there a difference between light intensity, moderate intensity, and vigorous intensity? Is there a dose-response association? And finally, potentially the most important thing, are these associations causal? Previously, we relied on the Bradford-Hill criteria for establishing causation in observational research. It's obviously not possible to conduct a randomized controlled trial if you're interested in understanding the association between physical activity and, for example, cardiovascular disease or all-cause mortality. Nowadays, we are trying to refine the Bradford-Hill criteria from the 80s or 60s or 70s, and there are different modeling approaches we can use. The counterfactual modeling. We almost always try to draw directed acyclic graphs when we are trying to understand how different confounding factors affect the association we are interested in. And there are people looking into instrumental variable analysis or Mendelian randomizations and trying to use genetic markers for the exposure, in this case physical activity, as an instrumental variable and assess the association between that instrumental variable and the outcome of interest. Unfortunately, we don't have that many genetic markers for physical activity so far, but I'm quite sure they will evolve over time. So just give you a little bit of an understanding about the dose-response associations. We have known that physical activity is associated in a non-linear fashion with, in this case, risk for mortality. And data from self-reports clearly shows a reduced risk by increasing levels of moderate and vigorous physical activity. This is data from one of the largest systematic reviews on self-reported physical activity. And you can see that self-reported physical activity equivalent to the minimum dose from the World Health Organization, 150 minutes of moderate and vigorous activity per week, was associated with about 30% risk reduction for all-cause mortality. When we did a study, which we published in British Medical Journal in 2019, we used accelerometry and found that the risk reduction for a similar dose of about 150 minutes of moderate intensity was associated with a 60% risk reduction, which is remarkably stronger in magnitude compared to self-reports. And here you can see the similar shape from a study using vigorous intensity activity from the UK Biobank. You can see a very similar steep risk reduction early on by small changes in physical activity and leveling off because people don't do that much of vigorous intensity activity. Another thing I would discuss in detail during my presentation in Mexico is this paper which we published in the Lancet a couple of months ago, where we built on Jeffrey Rose's strategy of a population-based strategy or a high-risk strategy. If you use a high-risk strategy, you are focusing on those ones who are very high risk. In this case, those ones are really inactive. And this is a benefit for a small part of the population compared to a population-based approach where we try to shift the entire distribution, making the entire population a little bit more active, which may then have a massive population health gain. So I'm going to discuss this paper in detail and give you some updates on some of the findings from that paper. So by that, I just want to summarize what I'm going to discuss. The early validation studies, giving just a brief update on that. Going to discuss a little bit about descriptive epidemiology, but then mainly focusing on the associations with health outcomes. And by that, thanks for listening, and I hope to see many of you in Merida in a couple of months' time. Thank you.
Thank you very much, Ulf. So we will move on now to our second speaker. However, if there are any questions for this, Ulf will join our panel discussion at the end. So there is a Q&A function for our webinar attendees. If there are any questions that you would like to ask Ulf, please do put them in now. You don't have to wait until the end, and we'll start to work through those when we get to the discussion part of today's webinar. So it's my pleasure now to introduce our second speaker, Dr. Vanessa Garcia-Larsen. Vanessa is the Chief of the Risk Factors and Nutrition Unit at PAHO WHO. So I'll stop sharing my screen. I believe I already have. So I will now hand over to Vanessa. You can share your screen and start your presentation. Thank you very much.
Okay, great. Thank you. Thank you so much, Sjaan. And thank you all for setting the scene for the topics we are going to be addressing during the upcoming Congress. So that's really great. As way of introduction, as you all know, physical inactivity is one of the key risk factors for non-communicable diseases, including cardiovascular disease, diabetes, cancer, and chronic respiratory conditions. And together, all these conditions account for about 80% of all deaths in the region of the Americas, many of which were premature or preventable. And therefore, for us, understanding the current status of physical activity and supporting policies in the region, as well as identifying areas where the Pan American Health Organization can support countries, is a priority. So as a quick background, the Global Action Plan on Physical Activity, or GAPA, is a framework for policy implementation from 2018 to 2030 and was developed by WHO. It is comprised of effective policies to address promotion of physical activity at the population level, and it includes multiple levels of social and ecological models addressing individual knowledge and mindsets, environmental modifications to increase the access to physical activity, providing opportunities and programs for physical activity, and also national policy frameworks and governance to support physical activity. So here you'll see that approximately half of the countries in the American region have poor progress toward reaching GAPA policy gaps, which means that less than half of the recommended policies have been implemented. And these countries are predominantly in the Caribbean and Central American region. And reflective of this uneven policy landscape, the data shows a worsening status of physical inactivity in nearly all the countries in the region of the Americas as of 2022. A 2024 global assessment similarly indicated that no country in the Americas is on track to meet the GAPA 2030 physical inactivity reduction goal of 15% compared to 2016 levels. And given this context, the Pan American Health Organization is supporting countries to implement the policies and also monitoring frameworks needed to promote physical activity at the population level. And so far, we've been able to support several achievements. At the national level, we've supported countries in adopting national guidelines and policies on physical activity. And one huge achievement last summer was supporting Chile through the approval of a policy mandating 60 minutes of physical activity in schools every day. So as Ulf was flagging the Swedish flag, I'm going to raise the Chilean and British and American flags here as well to reflect the progress we've done in support to all these countries. So probably I'm also biased. We've also provided guidance to countries on the adoption of GAPA and provided technical cooperation to countries to adapt WHO guidelines on physical activity. And here's another spotlight from last spring, which was supporting Panama through the adoption of an intersectoral strategy on physical activity, which was led by the Ministry of Health and the Ministry of Education, along with the adoption of national guidelines and an agreement to foster physical activity in schools. We've also supported dissemination of guidance on physical activity at sub-regional webinars and incorporated physical activity as a priority in the sub-regional program of cooperation for Central America. And lastly, for the region, we've collaborated with the Organization of American States, OAS, to ensure physical activity was included in the hemispheric program on healthy food policy, food and physical activity policies in school environments, and advocated, of course, to incorporate a commitment to increasing physical activity as part of PAHO's Regional Plan of Action on NCDs 2025-2030. So we've continued to offer support for prioritization of physical activity promotion through a few different ongoing campaigns and initiatives. First is through supporting countries to adopt the WHO-developed toolkit on integration of physical activity in primary healthcare, focusing specifically on the guidance for decision makers at this stage. And PAHO, along with WHO, developed a roadmap outlined here on the left side of the screen, guiding countries towards sustained implementation of physical activity counseling in primary care settings. And PAHO recently organized representatives from South, Central, and North America, along with Spanish and speaking Caribbean countries in November 2025, to facilitate sharing of country experiences, identify common barriers to policy implementation across countries, and support early development of country roadmaps in various breakout sessions. And follow-up and support for implementation is ongoing at the moment, and we plan to share details of these findings in the upcoming Congress. Secondly, PAHO is also making progress in the development and piloting of tools to support the investment case for physical activity interventions. And one way we're achieving this is through the development of a user-friendly Shiny tool that aids policymakers through evaluating the potential health and economic gains from scaling up WHO cost-effective interventions to reduce physical inactivity. And this tool is interactive, allowing users to rescale assumptions, time horizons, and intervention choices tailored to their country's context to be able to better answer policy-relevant questions. outputs for this tool are explored across 5 tabs that cover prevalence of physical inactivity, the cost of a physically inactive population in terms of healthcare, costs of physical inactivity attributable NCDs, attributable disability-adjusted life years to physical inactivity, and also the health and economic gains to implementing interventions to ultimately guide the user towards the policy option that offers the best value for investment. And again, findings from the R-Shiny tool that we are developing, along with an additional value of implementation analysis, are planned to be shared at the upcoming Congress as well. And another way in which PAHO is actively supporting the case of investment on physical inactivity is through the adoption and utilization of WHO HIT tool. After recently concluding a breakdown of inputs and resources to utilize the HIT tool in countries, the next steps will be to propose the use to national authorities in Brazil, Mexico, and Panama, particularly as it relates to decision-making processes for urban planning and building environment projects. And lastly, in collaboration with various academic partners in the US and also in Central and South America, we are supporting the adoption of the acceleration plan to stop obesity in select front-runner countries. Given that the Americas is the region with the highest prevalence of adult obesity across all WHO regions, addressing this health outcome is, of course, a priority for the Pan American Health Organization and our member states. And through various modeling exercises, we hope to provide health and economic evidence to policymakers to support the increased implementation of the various strategies offered within the acceleration plan to stop obesity. So after this brief overview of the work that we are doing here at the Pan American Health Organization to support physical activity in the region, this leads us to looking ahead at the upcoming Congress, where we plan to present 3 abstracts related to some of outgoing projects. I was just doubting, I haven't heard the results, so we hope we're in with a chance. These are really nice pieces of science implementation research demonstrating the applicability of the tools that we are developing, and also highlighting the relevance of integrating work with member states when it comes to advancing the effective implementation of physical activity strategies. So I very much look forward to sharing these results and addressing more broadly also the problem and challenge of physical activity throughout the region. So with that, I think I'm on time, and I'd like to thank you all, and I look very much forward to participating in this Congress. Thank you. And thank you again for inviting the Pan American Health Organization to sponsor ISPAH.
Excellent. Thank you very much, Vanessa. So if you could just drop your slides. Wonderful, thank you. So we shall move into our panel discussion. So Vanessa and Ulf will be joined by Dr. Deborah Salvo, who's an Associate Professor of Kinesiology and Health Education at the University of Texas at Austin. Deb is also President-elect of ISPAH. Deb is here in both capacities, of course, but University of Texas at Austin is one of our local hosts. Our second person to join the panel, along with Ulf and Vanessa, is Dr. Alejandra Jáuregui, who is the Director of Physical Activity and Nutrition. You may need to help me, Ali, with that, because that is in Spanish there, so you may want to introduce yourself, but take it away. You can finish that little bit to make sure I don't mess it up for you.
Oh, I didn't notice it was in Spanish, but thank you for the introduction. I am Director of the Nutrition Surveillance and the leader of the Physical Activity Research Group at the National Institute of Public Health in Mexico.
Thank you very much, Ali. One thing I have learnt as president of the society working with our conference in Mexico is not to attempt Spanish with my Australian accent. So thank you. I see we do have, and INSP is our local host along with the University of Texas at Austin. So I see we do have a couple of questions coming through on the Q&A. Excellent comms lead Diana will be helping with those that come through in Spanish. Deb, do you want to, Diana, do you want to help, or has Fanny actually put that in both languages kindly for us?
So I believe it is both languages, but I can say the first one that pops up on my feed. Fanny Castillo dice, hola, muy interesante la exposición. ¿Qué me puede decir sobre la importancia de caminar como actividad? ¿Qué me puede decir sobre la importancia de caminar como actividad aeróbica? He escuchado que algunos expertos comentan que las actividades de fuerza o musculación son más significativas para la salud. ¿Cómo se compara caminar con este tipo de ejercicio y qué beneficios específicos aporta?
So, Ulf, I can go first if you want. So,
Sure.
we have such a huge challenge implementing some of the physical activity guidelines because we are meant to do vigorous exercise 3-4 times a week, 150 minutes a week. And there is recent evidence demonstrating that if we move, we start seeing benefits. And now we might not need to walk all 10,000 steps, which is good in itself, but if we can't manage 10,000 steps, there is evidence showing that fewer steps are okay. So if we move more, and again, I think the dialogue is changing a little bit. We are now promoting that we move more rather than that we engage in intense physical activity, which we lose the will to live halfway through quite often. We start with all the best intentions, but it's too hard. And what the evidence shows is that if we move more, cardiovascular parameters like blood pressure improve over time. There is also evidence that some markers of inflammation, low-grade systemic inflammation, stabilize, and the and levels of lipids also go down. The good lipids stay same, but bad lipid profiles tend to improve. So there are certainly benefits in moving more, even if it is just walking.
Thank you very much, Vanessa. Ulf, do you want to add anything to that?
Yeah. I mean, I think first the WHO recommendations recommend both aerobic exercise with at least moderate intensity, like brisk walking, and strength conditioning exercises twice a week. I think the combination, or I'm quite sure there's data showing that the combination of both aerobic and strengthening exercises are the optimal. It might be different between different population groups. It's probably more important for elderly people to do more strength training and balance training to reduce the risk of falls and fractures. But if we look at the data, and there was a paper, I don't remember exactly the citation now, but there was a recently published paper looking at both strength and aerobic exercise or physical activity, and the benefits were greater for aerobic exercise compared to, or aerobic physical activity compared to strength training, but both had benefits, and the combination was obviously the best one.
May I add something, Sjaan?
Oh, of course.
Bueno, voy a responder en español, ya que la pregunta vino en español, gracias. Creo que además de todos los excelentes puntos que comentan la doctora Garcia-Larsen y el doctor Ekelund, también hay que considerar que a nivel de investigación, para aquellos de ustedes que les interese, todavía no tenemos excelentes estimados de cuánto se mueven las poblaciones desde el conducto o desde el punto de vista de fuerza muscular. Si bien los acelerómetros e incluso hoy día los teléfonos, los smartphones nos permiten tener un estimado de actividad aeróbica bastante preciso, como nos comentó el doctor Ekelund, no tenemos ese tipo eh, de aparatos para medir actividad física por fuerza muscular. Entonces creo que todo ese campo de investigación, tanto de medirla bien y al medirla bien ver sus asociaciones mucho más precisas con desenlaces en salud, es un área de crecimiento importante. Del punto de vista de la caminata, creo que es importante mencionar que en nuestra región del mundo, en las Américas y en particular Latinoamérica, como hay mucha actividad física que ocurre por transporte, por caminar de un lado a otro, como no todo el mundo tiene acceso a los automóviles y esas cosas, ahí sí vemos mucha caminata, pero obviamente hay que cuestionar las condiciones y el motivo por el cual ocurre e investigar si realmente trae los mismos beneficios, especialmente en temas como salud mental, calidad de vida, no nada más el aspecto fisiológico. Entonces creo que hay muchas buenas preguntas de investigación que tienen muchas implicaciones para la política y la promoción de actividad física.
Thank you very much, Deb. Ali, did you want to add anything before we move on to the next question?
Había una pregunta en el chat que nos decía que si la recomendación de los 150 minutos por semana es para cualquier edad. La recomendación de ser 150 minutos por semana aplica para personas de 18 años en adelante, independientemente si son adultos, adultos mayores, mujeres, hombres, personas con enfermedad crónica, mujeres embarazadas. Aplica de los 18 años en adelante, y algo por aclarar es que es el mínimo que deberíamos de estar realizando para obtener beneficios para la salud. Es decir, se obtienen más beneficios, por ejemplo, si hacemos 200, 300 por semana.
Great, thank you very much. We have a question from Stephanie Prince-Ware, who's asking if there's going to be any ISPAH workshops on the heat tool. Vanessa, I wonder if you could just give an insight as to what you might be able to present on that at the conference.
On which? On the tools?
The heat tool.
Yes, we are producing some data on the heat tool. We do have a number of countries that are actively engaged in the implementation. But yeah, we hope to share more results during the Congress. We have about 7 or 8 countries who are actively engaged in the implementation of these tools, but certainly not enough. But yes, of course, we hope to share more, engage more countries if they're interested in, because all these activities, of course, require multi-sectoral collaboration. And so it's not enough to speak to one specific sector, but we very much hope to be able to engage more countries in the implementation of the heat tool. But we have to, whenever we try to implement these tools, we need to take into account the national context, the urban context of these, of how suitable it might be. So, for example, if it involves cycling, is it safe to cycle? Is it feasible? Are there enough urban considerations in place to make it possible for the general population to cycle more? So it has a number of dimensions that need to be taken into account. So it's not very straightforward. It's one of those initiatives that we know generates huge amounts of benefits, but it requires the integration of several sectors of society to make it happen. It's different to when we say move more, walk more, exercise 2-3 times a week, because the responsibility in some way is almost entirely on the individual, though we also know that there has to be an appropriate environment for that. So there are challenges with the heat tool, but it's certainly a very important element of the work we are trying to increase in the region. It works.
Thank you very much. Thank you. So we are fortunate that Vanessa, I believe, will be joining us for a symposium, for a dedicated symposium session at the ISPAH Congress to expand on these topics. There's a couple of short follow-up questions, Vanessa. Are there any any courses on these subjects available at the WHO Academy? And are any of your colleagues coming from WHO?
Other colleagues, I don't know at this stage if we have. I'm sorry, I should know.
That's okay.
I don't know, but I hope that there will be. I mean, PAHO is the regional office for the WHO, so we are the WHO as well, but we are the regional office for the Americas. So I know it creates some confusion when we say PAHO WHO, but we are WHO as well. So is anyone from WHO coming? Yes, I'm coming, and perhaps some of my colleagues here are also going to be joining us. And what was the other question? If there are any yes, so there are some webinars that we've done on the implementation of physical activity tools. We've done a couple of, and I'll find the links and see if I can share here in the chat. But PAHO has several resources on the use. I'll look them up and I'll put them here. I don't know if directly to HEAT, but the WHO Academy might have something. I'll look it up and I'll post it here.
Wonderful, thank you. While you do that, we might move on to a couple more questions, just conscious of time here. Diana, can I please get you to help?
Yeah, I'm on it. So the next question viene de Silvia. Silvia nos pregunta o nos dice, ¿debería promoverse la pausa activa en centros de trabajo? El tiempo que se permanece inactivo, sobre todo en oficinas, es bastante perjudicial, aún más si se trabaja en computadora.
¿Puedo comenzar? Bueno, sí, creo que cualquier tipo de estrategia, obviamente de preferencia basadas en evidencia, y sí hay evidencia para las pausas activas, tanto en lugares de trabajo como en centros escolares, también, los active breaks, que nos ayuden a meter más minutos de actividad física de preferencia moderada, vigorosa en la jornada diaria de las personas, tiene beneficios. Realmente si es a través de pausas activas o si es a través de otros programas, no es que no importe, pero todo cuenta. En particular, un punto que mencionaste en la pregunta es para la gente que tiene trabajos extremadamente sedentarios. Creo que ahí se puede dar como un doble gane, ¿no? Un ganar-ganar, que es reducir un comportamiento que también es nocivo para la salud, y el doctor Ekelund ha hecho estudios muy buenos de esta comparativa de las contribuciones a los desenlaces en salud del tiempo sedentario y de la actividad física, y sabemos que ambos son muy importantes. Entonces, si se puede sustituir tiempo sedentario por tiempo activo, y de preferencia activo en intensidades mayores que menores, pues sería el ganar-ganar. Pero si no, si se puede sustituir algo de tiempo sedentario, aunque fuera por actividad ligera, moderada, también es ganar. Entonces, creo que desde ese punto de vista, sí, lo que se puede hacer desde el punto de vista de políticas y programas, como este tipo de programas, todo cuenta.
I've just shared a link here in the chat, a toolkit for physical activity and a couple of fact sheets that we also have available. So you should be able to access that if you're interested in more information on what's available in terms of training material for physical activity.
Great, thank you, Vanessa. And thank you, Deb, for the answer to that previous question. Diana, back to you.
Yep, we have another question. The next one is, ¿cómo recomiendan controlar la influencia de la publicidad y los intereses económicos privados para que no obstaculicen la adopción de políticas saludables? Esta viene de Rodrigo.
Yo puedo tomar esa. Lo primero que es importante que reconozcamos es justo que La actividad física ha sido utilizada por la industria alimentaria, sobre todo la Big Food, para promover actividad física, pero a la vez para justificar el que el enfoque se haga hacia la actividad física y no hacia la alimentación. Y sobre todo dejando la responsabilidad a nivel individual. Estas son estrategias que ya están más que evidenciadas en la literatura científica de cómo actúa la industria alimentaria, la industria del tabaco y del alcohol también, y de las apuestas. Entonces, el primer paso que debemos hacer es promover que estos conflictos de intereses se conozcan por todos los investigadores. En América Latina hay mucha conciencia al respecto porque estamos expuestos a una mayor cantidad de publicidad de influencias comerciales y no pasa lo mismo en otras regiones del país. Entonces, lo primero es que los investigadores no nos prestemos a este tipo de prácticas que muchas veces son muy sutiles. El que nosotros participemos, por ejemplo, en conferencias o que aceptemos financiamientos de parte de estas industrias valida sus productos. En inglés se llama endorsement by association. Y hay otro tipo de mecanismos a través de los cuales la industria alimentaria y estas otras industrias utilizan la actividad física em, para limpiar, ¿no? su imagen. Entonces, lo primero es hacer conciencia y una vez que tengamos una postura definida, mantenernos firmes. Y bueno, a nivel político, yo supongo que Vanessa nos puede hablar un poco más.
Oh no, we were just trying to make the links available to all the people joining us here. I heard the word politics, and I'm not sure I want to get into that. But certainly, whenever we try to implement public health policies or any policies that contribute to the reduction of non-communicable diseases, we need to work with governments, with states, with authorities, and we also need to have primary healthcare sector, we need to have health professionals and the education sector, and very importantly, also civil society. So by all means, we need to have political will to implement certain laws and to establish a regulatory framework that is going to enable us to move forward with certain legislative processes. And that's always critical if we want benefits to reach out to all the population. But it's something that we at PAHO put a huge amount of effort into, because for us it's extremely important that the policies and recommendations that are evidence-based and then we know generate benefits are available nationally. And partly because I strongly believe we should take away the responsibility of an individual to eat better, to move more, to live in a healthier environment. We need to create a space where that's easily promoted and facilitated for populations. And from that perspective, of course, we need political engagement and political will to implement these policies. And that's why we are generating all this evidence from PAHO. And I know many other colleagues and researchers are working on that as well, demonstrating the value of implementation of a scaling up physical activity strategies is huge. And so when we present this evidence, we very much hope that is going to motivate countries to get them through the legislative processes that are needed to make them law. We've been fairly successful. Some of my colleagues here at PAHO have been leading very important work to facilitate technical support to implement laws for the reduction of availability of harmful food products, for example. And so with physical activity, I believe we have to follow similar steps to ensure that people have access to healthier options at all times. Physical activity is part of that.
Sí, puedo agregar un comentario más de esto. Creo que también teniendo un pensamiento en sistemas, hay que ver el otro lado, que es que cuando hay huecos de financiamiento, de investigación, de políticas o de programas, de la implementación, de infraestructura, de lo que sea, la industria los va a tomar. Entonces, también necesitamos que aquellos de ustedes que tengan injerencia en la decisión de presupuestos, ya sea de investigación o de implementación de programas o de infraestructura, lo utilicen para la actividad física y que sean los fondos públicos los que llenen esos vacíos, porque si no le estamos dejando ahí a la industria algo y también es difícil a veces pensar que los individuos, especialmente en posiciones vulnerables, van a negar la ayuda si es de infraestructura, pero con una marca, etcétera. Si viene con el, entre comillas, beneficio de que ahora tienes canchas en tu barrio para jugar algo, etcétera. Entonces, no deberíamos dejar esos vacíos desde los fondos públicos.
Thank you. I think today has been a great indicator of some of the excellent discussions that we'll be able to continue in Merida in October. I'm conscious that there are a couple of questions here that we won't be able to get to within time. So as we wrap up, I wonder if our panelists could take a look at those Q&As, if there is any responses that you might have to some of those outstanding questions. You can type an answer to those as we spend the last few minutes wrapping up today. So I would like to invite Ali to say a few words about our host city,
Sí,
Merida.
claro que sí. Bueno, primero que nada, quisiera empezar diciendo que Mérida es la ciudad más segura en todo México. Tiene niveles de seguridad parecidos a muchas ciudades europeas y se caracteriza por su gran caminabilidad. Es una ciudad muy tranquila, llena de historia y cultura. Em, y algo que la caracteriza es que en la ciudad de Mérida van a tener acceso a una cultura culinaria muy rica. Hay una serie de preparaciones típicas del sur de México que valen mucho la pena. Eh, También es el lugar donde cayó en el meteorito que acabó con los dinosaurios. Entonces, en todo Mérida y muy cerca de Mérida hay cenotes que son hermosos, son lugares muy turísticos, muy bonitos, y hay toda una serie de lugares donde ustedes pueden pasar el día en tours pequeños, ¿no? Conocer ruinas, pirámides, etcétera. Está Progreso, a 30 minutos tenemos la playa y en sí la ciudad de Mérida es una de las más amigables, muy hermosas y muy fácil de moverse. Entonces los esperamos en octubre en nuestro próximo congreso.
Fantástico. I didn't know about the meteoritos y los dinosaurs. So definitely coming over now.
Thank you very much. Yes, I had the great privilege of being able to visit Merida when we were looking for the site for the conference, and we had a great few days. There's a wonderful park for physical activity. It's a very, very walkable city, as Ali has shared. And I'm very much looking forward to being back there to host our conference in October. So you'll see there is a QR code that I've been sharing on the screen that goes to our Congress website. We do have late-breaking abstracts currently open, which are due July 17th. So we please do encourage you to join us in October and take the opportunity with these late-breaking abstracts to present some of your best and most recent work. And as we wrap up today. I just want to thank our speakers very much for joining us. Thank you very much to PAHO. We're very excited that you have joined us as a co-sponsor of the ISPAH Congress, and our local hosts, Ali and Deb, representing your respective institutions. Thank you very much, Ulf and Vanessa, for your presentations for today, and for all of you for joining us from wherever you might be in the world. And we will look forward to hopefully seeing you in October in Mexico, but if not, at another opportunity as we gather to continue to discuss and push forward physical activity and public health. Thank you very much, everybody.
Thank you all very much. Thank you, Jen. Thank you, Deborah. Bye. Bye. See you soon.
Thank you.
Thank you.
Jen.
Nos vemos en Mérida.
Nos vemos en Mérida. Chao.